Good morning, everyone. My name is Gerry Pape. I'm part of the Stewards of Change team. I guess if Rick was a recovering Fed, I guess then I'm a recovering private provider or industry person. Anyway, one of the participants for all the ideas, innovations, thought leadership, implementation, operations, for many of the things we collectively do is our industry partners and private providers. So our next session is a chance to hear from some of our industry partners, some of the thought leadership, the innovations, and some of our symposium sponsors. We have it in two sections. The first section we'll hear from individual speeches, and then I'll turn it over to Vernon, one of the co-founders of Stewards of Change, who will work in a fishbowl and explain what that is, and we'll have some other individual contributions. Our speakers for today are Bill O'Leary. Bill is the Executive Director for Microsoft for Health and Human Services. He's a regular participant with us on many of our symposiums. He also is the former Secretary for Health and Human Services in Massachusetts for many governor administrations. Following that, we'll have two folks from Currum Software. Martin Duggan, who is the Vice President in charge of market strategy, will share with us some thoughts and some global perspectives, followed by Walt Sedlazek, who's the director at Currum Software and part of the CTO organization. Now, if you're following the printed program, you'll see that Bill's talk was going to be shared with Nick Machione from San Diego. Nick got a call late last week, a request to come to a meeting this morning at the White House. I am sure he spent many sleepless nights. The symposium, the White House, the symposium, White House. He probably chose wisely, and he is at the White House at a meeting this morning. Also on the printed program, Ronan Rooney was to speak, the co-founder and CTO of Currum Software. He had a family emergency that came up. He's probably sitting there saying it takes at least two people to replace me, but I think for all us that know Martin and Walt, we know they're both capable, very capable of providing that message. So with that, Bill, it's all yours.
Thanks, Gerry.
Here, sir. Clicker, and you can follow it there.
Good.
There.
Thanks. Well, thank you. It's great. It's great to be here again with Stewards. First time out of Harvard, actually, into Johns Hopkins. This is really a great place. And it's also nice to be with a lot of the groups that we've spent so much time together on putting this together in the early years, and also focusing on the whole connected strategies that have been reflected in government and private sector and communities. And it was nice to see the recognition that Daniel extended to Rick last night has been kind of giant to many of us in this industry for such a long time. Gerry was saying that, first of all, let me say this, in terms of San Diego, because some of my discussion is going to be around San Diego. Actually, as he said, Nick was going to speak with me here. I had been imploring Nick that I thought that his team could present the story more effectively than him, as I think Harry did. But I couldn't get that through to him, so I had some of Microsoft government affairs people extend an invitation to him to go to the White House, and when he gets there, he's not going to get in. What I'm going to talk about is much of the same themes, actually many of the same themes that we saw in the last part of the last conversation. And somewhat from a high level around where we see health and human services connecting over the next number of years, and the role of business in that, and how that's impacted by impacts in the economy, and models that we're starting to see emanating around the country that are pretty interesting. And so that's the gist of where I'm going to go, and I'll take it when we get to the model part. I'll talk a little bit about how one of the things that we have been thinking more and more in the last year, 18 months, has been we have heard very similar comments coming from governors, mayors, CEOs of businesses we're dealing with, as it relates to health care. And I'm going to repeat what I'm saying now in a few minutes, but in each instance, the discussion is not health care alone. So as we're talking here about health and human services, When they're talking to us, they're talking about healthcare in the context of economic development and in many instances in the context of education. In other words, their concern is economic development, period. When you talk about health, their concern is about the health access care outcomes. Their concern is about the cost of health and how it's cutting back other government spending. Businesses are concerned in the same vein. So in that regard, what we're beginning to see is just a significant, in many ways, activity occurring that isn't seen as much from groups or in any one part of those arenas. But when you look across them, we're seeing a lot happen. And I'll get into some of that, where companies such as General Electric in certain communities are actually going into the community as a stakeholder because they're the biggest employer in a different way, and that having a company convene the payers, providers, and government is very interesting. Discussions like that are starting to occur. So let me walk through. This is what I'll talk a little bit about. Some of these are stuff we've talked about the last few years, but I want to bring it up to the present and what I'm thinking. One is this whole convergence of markets discussion. The role of the consumer as being an enabler right now. So for many years, everybody's been on both the health policy debate and in the connected health and human service debate, people have talked about a consumer-centric approach. And then in many instances, they were concerned that the consumer wasn't taking an active and this is particularly true in health policy when we get to that in a minute. But you need the consumer active in the game to hold the systems accountable. All right, we're starting to see the consumer become much, much more active, partly because of changes in the market, public and private, and partly because of the ubiquity of technology that they're using. And then some themes on technology as an innovator, and then this healthy communities theme as kind of an intersect of public and private collaboration. This is a slide that actually, this is a slide that about 4 years ago, maybe 3 or 4 years ago, I had gone around to different parts of the country. Actually, Daniel was with me in a number of those. We had the governors invite us in. This is right on when ARA passed. The governors invite us in, and in a number of the instances, they also invited Rick in from CMS. And we went into New York, West Virginia, Alabama, California, Wyoming, to have a discussion about where's this market going. This slide builds, and for time I didn't have it build, but to give you a sense of where we were going with this discussion was this. Forget the vertical slide for a moment. We were starting to see on the horizontal, in this whole connected HHS theme, that we were now looking at CMS and Medicaid as, in many ways, the question would be how can we leverage both that technology and business strategy ways to connect to populations that are other HHS populations. So that's what that horizontal slide is. The interesting thing, and where this slide builds, would have been on the vertical. When ARA passed, with solid bipartisan support in terms of the prioritization of the health IT piece, that actually drove and made inevitable the intersect of the commercial and the public sector health markets. Because, for example, on the EHRs, the funding for them went through Medicare or through Medicaid in the states down to the providers, right? That was a giant, just that thing was giant. I remember having a discussion with a few years back, Senator Manchin and I gave a talk at Yale. But when he was governor, that was a big deal to him because he said, we are very concerned as governors about owning the health reform. This is before health reform, but those themes. In other words, this is a commercial market that's got to act, and government can't pay for everything. So we don't want to have anybody assume that we're going to pay as governors for the whole health information exchange in our state. But now he had a vested interest as a governor with his Medicaid agency in making sure that they were all at the table with all of his payers and providers, because they were going to be held accountable for the $20 billion in EHR funding that came down through CMS and Medicaid to the states. So the reason that was relevant from our view at the time is we believed you were going to, and this is before health reform passed, but we believed you were going to start to see, because of the financing schemes, the scenarios that would play out of this, models that would emanate now at the intersect of those systems. And we've seen a lot of that, and I'll talk about that in a moment. So for instance, ACO and medical home models coming both out of the CMS world, federally qualified health centers, but now also emanating from Care First Blue Cross out of Maryland, or WellPoint, or Wellmark and the governor of Iowa. Lots of commercial models that are coming out of this intersect of the markets. So I'm going to talk a bit about that because we're spending as much time looking at those models from the perspective of those businesses and how they're trying to integrate or interact into government, mostly with municipal and city and county groups such as San Diego. So we did another piece, the paper I wrote a few years back called Urgency to Innovation. But this was when I said a moment ago that we spent about 6 months where we were trying to get trying to get a handle on, and still are obviously, but the question became, what's going to happen in this marketplace if health reform is overturned? Which could be, right? I mean, and then I won't, for time, I'm not going to get into that, but there are various machinations of that, the key being the individual mandate, but also the Medicaid expansion and the rest of the components. But the theme on that was when we started talking with government leaders and business leaders, they were less, obviously, like if you're a payer, you have a giant interest in that. If you're running Medicaid, you have a giant interest in that, right? But they were also saying no matter what happens with health reform, we have some giant pressures coming on us that are not going to back off. And that discussion always started with the cost of health care and the impact on the businesses and on government. So that slide really was just to frame the context of that. So you had Medicaid and Medicare costs rising. You had state Medicaid spending crowding education spending. In some instances, transportation spending. In some instances, other parts of local aid. And NGA's talked a lot about that. You have, you've got, on the business side, it's really, you wouldn't have had this question in the top 5 bullets of a CEO of a major Fortune 500 company. It is in the top 3 bullets of them right now. So you have, if you were to look at, I'll mention General Electric again. So Immalt is, the CEO is, I think, chairing one of the president's task force on either workforce or jobs. But at the same time, he has been grappling with location of workers. He's got a lot of workers in China. Now, when you look at that dynamic, I gave a talk a few weeks ago, and one of the people from his office came to me afterwards because it was that theme. It was this discussion down here, right? Which was they are spending 18% of GDP in the US on healthcare costs, 4.5% in China, 8.5% in Europe. That is a giant impact on business in the US in terms of how they decide what they're going to do. And then in terms of consumers, workers paying 47% more for health care, wages increasing 18%, impact on salaries. So the theme there, the overarching theme there being cost is a giant factor, which we know, but it is also a mobilizing factor for stakeholders that often wouldn't otherwise be at the table. Okay. So we have a policy shift, which I'll summarize in a second. But to some extent, if you were to go back to HIPAA, if you look at the underpinnings of health reform legislation, frankly, if you were to look at any health policy emanating from the federal government, the states, or most of the policy groups, going back, say, 15, 20 years, it's always a three-legged stool of we have to improve access, quality, and cost. We have to deal with finance or cost. Different emphasis on different pieces. So you'll have opponents to health reform say too much focus was on access and not enough on cost. Others will say we got to deal with the access issue first and deal with the cost second, that kind of thing, right? Right now, we're in a period where the question of access is increasingly more than being seen as more than insurance coverage. We have a primary care shortage. In rural states, particularly, people are sensing that. Or even in urban states, when you get into the rural parts of those states. Like I'm from Massachusetts. You go to the Berkshire County, they have a crisis on primary care coverage out there right now. You've got an increasing demand for care coordination, both out of the policy arena meaning too many people in emergency rooms, focus on the fact that we could do better with medical homes and integrate information and connect the dots for health, across health, and even to human services. You've got to focus out of all of that on service delivery modernization, which I'll come back to in a moment, because that is where you see an awful lot of models emanating both from the commercial and the public sector right now. So the access issue becomes a broader issue. The improved quality starts to focus on the kind of metrics that San Diego's talking about. I'm getting right down to it. Have we and can we measure? I mean, one of the things 5 years ago that impressed me about San Diego, I was given a talk there last month, was 5 years ago I was kind of blown away by how that county and the community had decided to tackle infant mortality, low birth weight babies, those themes, and how they had, with school nurses, and how they had measurably impacted and reduced the incidence of it. And they were holding themselves accountable to it. And now, as was said in that presentation, they've actually taken 5 or 6 indicators, whether it's the blue zones, multiple others, and they are putting it right the hell out there. We're going to drop this incidence of this indicator by X amount or hold us accountable, right? So you're starting to see a lot more on that. CMS is in that situation right now. So CMS is in a situation where you would go from, well, we were claims processing, we did claims work, but now we're doing performance management. What does that mean in terms of the information we have to get back to providers and measure and communicate? And a lot of this improved quality focuses on prevention and wellness, which you also heard in San Diego, but elsewhere as well, because from the businesses and the government perspective, that is tangible. 50% of the deaths in the country tied to 4 or 5 chronic diseases, and they account for 50% of all healthcare spending in America. And they are largely preventable, tied to personal or individual activity. So you see on the one hand the First Lady driving the discussion on obesity, but at the same time you see big businesses driving that discussion. So it's an area where you're seeing a lot of collaboration around those themes. Cost is, again, in that mix of the 3 access, quality, cost is now a more dominant theme. So it's not on even par with the other. It's actually becoming dominant in the eyes of the policymakers. And the overlap of priority among policy leaders, as I said earlier, is if you're talking to them. I did a thing in Massachusetts a few years ago, about 18 months ago, with Governor Patrick, where we suggested that it might make sense to convene a discussion around business and health, and he was all over that idea. And so he said that he would convene Governor Douglas, who was the Republican chair, I think, of the NGA, and health was his issue, as well as Governor Beebe from Arkansas, and then maybe 20 of the state HIT coordinators and virtually all of the health industry in Massachusetts and around New England, and then much of the IT industry in that world. But what struck me at the time, and it's also affected a lot of what we're doing right now, was he said, you know, I can't have a discussion about health, including what we're doing in Massachusetts on health reform. It is of no value if I don't tie that discussion into economic development. I can't take my eye off of jobs and economic development, even in a state that passed health reform. That is second to me on this topic. So you have to be able to frame that. We have to be able to get business at the table, because maybe we could create innovation zones around community care coordination, and I can drive a job strategy out of that. Okay, so an awful lot of focus with all of those groups. Any mayor in the country is going to tell you the same thing. Any one of them. I mean, we did this stuff in Chicago with Rahm Emanuel. That's it. What's the economic development implications and what are the jobs implications? And by the way, does it tie to education or could it? Because those are the things that are on my mind: health, education, economic development. That takes us to a healthy communities paradigm, which I'll get to in a second. Innovation will, in our theme there would be that we think innovation will occur at the intersect of consumer business and public health in many of those communities, and it will be enabled by the consumer, as I mentioned, enabled by technology, and it will spur new business and delivery models. So when I mentioned a moment ago, so this is, I think most people who looked at the policy and health the last number of years, this was the picture: improved access, cost, and quality. Now we think the picture is improved access, improved health, measurable metrics, improved health. Have you reduced the diabetes rate? Have you reduced the obesity rate? And also, from a performance management, can CMS and other payers start to measure the impact of the spending of their money on healthcare outcomes So that whole Medicaid managed care themes, the payers across the country, government payers are focusing on improved health. And then this third one, improved care, is this question of, it's an access and quality question, but it goes again to, do we have the right service delivery models to improve care and allow us to improve health? How do we get to medical homes? How do we get to accountable care communities? What's the role of business in all of that? So you've got in public sector. So we think those are the three kind of driving policy themes, and that cost one is now cutting across all of them. And the innovation will occur when you can start to talk about how do we develop models that ensure all three of those at lower cost. So just a few points about the consumer issue. I remember when I was Secretary of Health, I don't remember the actual percentages, but the percentages of the Medicaid population that had cell phones was pretty high, but not like today. I think it's like above 90% today. And the projection of the whole technology industry about what percentage of people with cell phones are going to have smartphones, including the lowest level income, is just rapid trend in that direction. Okay? So we see in Miami, and we're seeing in other places, and sometimes it emanates from health, and sometimes it extends into human services or into education, and sometimes emanating from business first. But what does that mean? That's low technology spurred on by the ubiquity of mobility, which is driven largely by the incredible advancements that came out of Apple a few years ago, right? So you're seeing that market just erupt. And then you get into this question of, so what does that mean? Well, it means Walgreens, CVS, Walmart, and a host of others are now texting people to remind them to take medication, because that's in their business interest, right? But it's also in the business interest for a state Medicaid director to figure out how the hell do we find a way to pay for that technology, if it's possible, right? Because if we can get a higher uptick of medication adherence for behavioral health or any of the highest risk populations, highest cost populations for Medicaid, that makes total sense for us to go there. So the reason that this flip of the consumer is pretty interesting right now, because technology, on the one hand, the consumers are digital natives now, so much of our discussions are passé almost. They're there. They are expecting access to information. And even though there's a gap between how this translates into government, the industry's already there, or it will be there. When you see the development and where the search engines are going, whether our search engine, Bing or Google or others, where that is, I mean, it's just, and how that ties to social media, and how you could have, if you chose to, have your personal health record tied to that, and then a social media connection that could help mentor you or keep you connected to make sure you take your meds. You're going to see that stuff everywhere in the next couple of years. And if it's slow starting on government, it's going to come out of Blue Cross Blue Shield across the country. So there's a lot about the consumer as a digital native changes it. The other thing that changes it is when and I'll give a personal example. I co-chaired the Massachusetts Healthcare Task Force for 2.5 years prior to the vote on health reform. But the groups that we had focusing on that were the same as those three pillars I mentioned earlier. So there was a administrative simplification issue, so there was a force. That was a technology one. Finance, quality, and access groups, right? And we had the whole health industry and business industry in Massachusetts, and then many of the very top leaders in the country, because we knew the outcome of this was likely to be something that would have a national discussion, right? And one of the biggest issues that we looked at the time was this consumer. The consumer was just not involved in, it was very hard to get to how you're going to drive the cost curve if the consumer's got no relationship to the cost of insurance or outcomes. Well, those questions are starting to shift right now. And part of it, again, is the digital native of the consumer. Part of it is the industry is rapidly, the health industry is rapidly trying to connect to the consumer. And then also the policy discussion at CMS and the government, and everybody's on. I mean, there's a debate around insurance exchanges is if health reform goes down, what will we see? But you will still see models that have emanated from a number of states around business and government exchanges occurring. Right? You're still going to see variations of these themes, all of which require and are playing off of a more active consumer. So consumer is now a significant enabler. Technology, similarly, is increasingly in this discussion. And I won't go into, I want to pull a note up that I have here in this thing. I won't go into in great detail into these, but these are examples. We're seeing technologies and solutions that enable health delivery system innovation, efficiencies, and improved outcomes. So some of those, you've got the ACOs. You got a community like San Diego saying they're going to be an accountable care community, right? You've got Health Choice Network in Florida and Miami, who's now doing everything from the back-end technology for like 10 or 15% of the federally qualified health centers in the country. But they're also have now decided that they're getting into the Medicaid managed care business, so that I think they're the 6th largest Medicaid managed care payer in the state. They also run the Extension Center. They're tied to the Health Insurance Exchange. They're doing school-based medical homes. So they've done models of medical homes in the schools to connect health and education and family health into the school, right? So you're seeing a lot of that start to happen in terms of delivery innovations. And as I said, you're seeing, on the business side, you're seeing companies like Walgreens or CVS that are moving from a pharmacy into community care coordination. So they're extending their thinking out to the consumer, out. Walmart's doing the same. In fact, there's just tons of activity playing in that marketplace around that. We're also seeing technologies that get and keep consumers engaged, and I mentioned a number of those a moment ago. I think some of the others, so a lot of it will be in this mobile device discussion. A lot of it will be the one-stop shopping and the eligibility themes, and both at the federal to state level, at the community level. You've got Elizabeth Mason and Single Stop doing benefit coordination across community colleges in multiple parts of the country now, and expanding that as a strategy to reduce dropout rates, and they're having an incredible impact. Washington White House Innovation Award for it. So you see that occurring. You see the work of Claudia and social interest solutions in this space. Just a lot going on that whole arena. We also are getting calls, and this is both at our company and our partners and our competitors, okay? We're starting to see, and I think it'll take 2 or 3 years to really see how this plays out, but we know it's happening because developers and people on their own and VCs are saying they're investing in building things because they see the market coming there, okay? So we're seeing the intersect of gaming devices like in Microsoft Kinect and Xbox, and search engines tied to Kinect and Xbox in our business, okay? So you can take that in the other businesses too. Where the theme becomes one of, can we reduce long-term care costs or recovery time, for instance, in rehab centers through telemedicine and applications over a Kinect device that is not just a gaming device, but that is actually a rehab for a hip injury or for other types of things like that. We've seen applications being built for blind people that are very similar to a Kinect device, which actually reads where they're walking so they don't need a dog. Right? We're seeing just tons of this stuff happen. We're seeing in post-traumatic stress, or like in military populations that have had real major industries in trauma, we're seeing discussions where you could hold a community session, like a group for post-traumatic stress, leveraging an application like Kinect, so that your avatar is actually in the room and you're talking, but you don't have to be there. Or you could be there from Germany and other parts of the world. You're going to see tons of those things coming out in the next few years. Partly because it's just a natural extension of people all of a sudden will be using their TV and their search engine and everything else. But also, particularly in the long-term care cost theme, there's a lot from the industry trying to figure out how do we get into that space. Integrating government and private sector efforts using technologies, I've mentioned to a number of those. Investing in shared services, cloud services, and emerging technologies. That's a discussion that we're having here today. I think the last couple of days, I think you're going to, you've got a big push coming on the whole infrastructure side of both federal government and state government in terms of, can we move this discussion to the cloud? What parts of it can we move to the cloud? How do we deal with security? I think this whole business thing is going to get more and more interesting, because as they start, so for instance, an interesting question would be, to which there's obviously no quick answer, is there hasn't been yet for how do we meld funding streams on technology, right? But an interesting question would be, in a community like a San Diego or a Chicago or a Miami or Cincinnati, if you're a mayor, how can you cover some of the backbone through the government? One of the people in the room raised this kind of thing the other day in terms of front end and back end stuff. But how could you have certain functions covered on the back end for the community, and how can they allow business to access that, and then have business build applications that they will give into that for the not-for-profits and the community providers? How do you get that level of innovation starting to occur? Yeah, I've got it here, 7. We're looking at building healthy communities as an example, the paradigm of just tracking that discussion nationally. And when we're talking about building healthy communities, it goes back to my point about policy leaders. The theme there being, and government leaders and business leaders, the theme there being that a healthy, educated, working community is to them a healthy community. And we're seeing an emergence of public and private partnerships, and some of the examples of where those things are playing out, connecting previously disparate government, commercial, and not-for-profit systems, breaking down barriers to internet access, digital divide. So you've seen a bunch of companies, including ourselves and Best Buy, starting to throw investments matching federal agencies to expand broadband access to parts of the country that hasn't had it. Support development of less costly shared services, empower increasingly IT-literate consumers. And as I said, being characterized by improvements in population, healthcare, education, and economy. And their dynamic business interests and overlapping business interests that cross those various stakeholders. And from the business community, that includes their bottom line. Can they get some handle on their healthcare costs? And their need for workers in a market where they know. That's why you see a lot of businesses interested on this whole single-stop community college thing. Because if they think, well, if we could get a bit of a handle on the healthcare piece and get a stream of workers coming in, and we're located in this community, that affects our bottom line. Also, you're seeing a whole level of thinking occurring on social entrepreneurship. Mark Lane, who's going to be talking at one of our pieces, was just appointed in Illinois by the governor to head up a discussion on this. But the whole role of businesses like Starbucks and others thinking about their role in the community, particularly in the communities which they're heavily located, as stakeholders more than business. And then new business models for health-related businesses is becoming giant. So payers are becoming providers in some ways. They're looking at accountable care models. Providers are looking at similar. How do we do accountable care models to control costs? Pharma is actually jumping into community care coordination. Businesses that were not even in health are getting into the health discussion. So we're seeing a lot of that. And then cutting-edge partnerships emerged to combat health and economic costs of chronic disease. As I mentioned, the impact of chronic disease in America. This starts to get tangible because it is very focused in terms of, well, we may have a lot of other things playing around the margin, but we actually, if we could marginally reduce diabetes and heart disease and by tackling obesity and activity, you can have a pretty significant cost curve just by percentages in that space. And so our view has been that the success in achieving healthy communities is impacted by progress and dissemination of this type of collaboration. And one of the things that we have been doing is convening discussions to review these models in different parts of the country. And I won't go into all of these, but the example being in Chicago, we did a forum in the fall with the Surgeon General and the Chamber of Commerce of Chicago. And what we've done is, and I've had discussions with NCL and some others about this recently, but what we've done is when we've been talking to mayors, for instance, we've been suggesting that we involve the largest businesses from that city that are indigenous to that city. Because they are not only important on the health side, but they are important as economic drivers for that tax base of that city. So we've had some pretty interesting discussions and some models that have emanated out of that. In Chicago, for instance, with Walgreens and Scott's Miracle-Gro and a number of other groups that are have been involved there. And then we took those themes and also the principles and went to San Diego about a month back with similar discussion. The mayor, the county advisors, the chairman of the county board, Nick and his team, Kaiser Permanente, which is based out there, Sharp Health, which is based out there. And in each instances in both these jurisdictions, and for time I'm not going to go into any depth on this, but we had come out of that models that I was talking about earlier. We had community models in public health that were now tied to business leaders on either the commercial health business side meaning businesses that are in the healthcare space or businesses that are trying to figure how they're going to engage government in this discussion right now. So and actually I don't have the slide on it, but we did a similar one in Miami as well, where we focused on education and health with the businesses Eduardo Padron and Single Stop, as well as the Health Choice Network. I would urge people to continue to follow this discussion. One of the reasons we have been able to get into it is because we don't have a vested interest as a company in the delivery of health care. You follow me? Even though we have some ubiquity in the technology that would be used end-to-end in the healthcare marketplace. But the business world and the government leaders have been saying, can we get some business groups in a discussion to help convene this? Because we're very concerned about the policy implications of what's going to happen, whether health reform stands or goes down, and we're trying to figure out models around community care coordination. So we're seeing a lot of that in a lot of our partners, both on the community side, whether it be NIC or General Electric, which, as I said, is starting to invest in communities where they're highly, they have big numbers of their employees. We're seeing them start to come to the table with the payers and providers and basically go right down to the architectures we're talking about here. And what pieces of them do they cover? And at least if they're going to build something on the business side, can it connect to what's going to happen on the government side, or vice versa? I wanted to leave with this. We are actually going to do a forum. A number of people in this room are going to be there with us in D.C. on Thursday. And it's going to be live broadcast. So we have many of the, in addition to, we're going to have, the San Diego team is going to be there, the Miami team is going to be there, Chicago is going to be there, the League of Cities, the Council of State Governments, the National Governors Association, all of those groups. And then we also have the National Minority Quality Forum, Kaiser Permanente, Johnson & Johnson. Each will be coming in talking about what they're doing in national scale. It not only the model, but the intersect of business and government. Okay, we're going to live stream that. So the forum we're doing is really only going to be about 40 of us. But we're actually live streaming it through those organizations to their membership nationally. So if any of you have an interest in that, just take down that website, because anybody who has an interest in following this, we really would like you to, because we want to continue the discussion past this. But it's hooked up, it's ready to go, and if you register on that site, you can either, you guys or anybody you think might have an interest, you could forward it to them to participate in the forum or part of it this Thursday. Thank you. Hey, as I leave, I have a 15-minute call. I don't want to look like I'm walking out on my friends here, but so I'm going to be coming in behind him when I come back in the room. Thank you.
Thank you, Bill. Good morning.
Morning.
Good morning. It's a pleasure to be here, and thank you very much for having us. As Gerry said, unfortunately Ronan Rooney couldn't be here due to a family crisis, so Walt and I are going to stand in for him. We work for Kiram Software, which until the end of this month is known as an IBM company. On July 1st we will be formally integrated into IBM. And that will be the largest investment that IBM has ever made in the government sector, and specifically in the social, health and human services type area. And it's a good sign for, I think, the industry and for us that the areas that we've been asked to look at and focus on are not just the social programs, but also the intersection to health as well. And we'll talk a lot about that when Walt talks about later on some of our areas of research. And I'm getting to that age where I can't actually read my notes. So glasses on or glasses off doesn't make much difference, really. What we're going to do is talk about two things. First of all, I'm going to talk about some new models of citizen engagement from an international perspective. It's one of the things that Daniel and Gerry asked us to do, was to give a view from around the world, and I guess I get the accent to do that. But I do spend a lot of time over here as well. But and then Walt is going to look at it from a slightly different perspective, particularly the integration of social programs and healthcare. And we've heard the term a lot in the last day and a half in terms of the social determinants of health and some of the things we're looking to do there. And that's particularly going to be a focus for us going forward inside IBM. So 3 examples I want to talk through, and I particularly want to highlight a couple of things I think that may be relevant to us here in the US. The first is Canada and something called Service Canada. And this was a wide government transformation, but I'm picking on one part of that transformation to show some of the things that have been done and can be done around the world. This is a functionally integrated application across 3 levels of government. And to pick up the point that Stephanie, I don't know if she's still here, was talking about yesterday in terms of functional integration, that's exactly what was done here, a life event for the birth of a child. So in Ontario, when you have a child, you register the child at the municipality. If you want a birth certificate, you get it from the province. And if you want to get the child tax credit, you first of all have to have a social insurance number, which is a bit like the SSN, and then you get that from one federal department, and then you apply to the equivalent to the IRS for your child tax credit. And there was nowhere in Ontario where you could do that in less than 3 or 4 months if you were really dedicated to it, because the time it took to go from one step to another, and of course there was nowhere where you could do it without driving between multiple offices and multiple interactions. So this transaction was integrated. There's a whole lot of reasons why it came about, and I don't have time to go through that. So now, when you actually register the child, all the information there is collected that you need to register the child. The only information you need to get your birth certificate is your credit card information, because in Ontario you have to pay for the birth certificate. Okay? The only information you have to apply to get a social insurance number is, guess what? Nothing. Everything that you needed to get a social insurance number was already collected at the birth registration. Everything. And to get the child tax credit, guess what you have to give for that? Nothing. Now, previously, you had to give the same information to every single one of those 4 different organisations, and now it's all integrated. Now, there's a couple of lessons that come out of this, and by the way, if you still want to do it the old way, if you don't want to share information with the federal government, you can still do it the same old crappy way it used to be. Right? It takes you a long time, but the uptake on this, and I don't have the latest numbers, but after 6 months, they were getting 98% of people transferring the information to the federal government. Now, I have to tell you, I do laugh about this a little bit, because I was trying to figure out who the 2% were, because by the time we finally got through the privacy people, and I'll come back to that in a second, the button that was there was saying, do you want to provide your information to the federal government? And the answer, of course, was yes, because what you got was free money. The incentive was very clearly there for the citizen, and that citizen engagement. And I come back to this quite a number of times. That citizen engagement, this was designed to be really easy to use, really easy and obvious why you should go through this process. And there was no issues about social exclusion, about people not having access to the internet. People found a way of doing it because it was so blindingly obvious. So the 2 learning points that I'd pick out. First of all, the lawyers all told us it was illegal. So we fired them. I say we because I was actually quite deeply involved in this project. Now, of course, in Canada and the federal government, you don't fire the lawyers, you actually just send them back to the Department of Justice. Right? So, and then the second lot came along, and they said the same thing, and we fired them. And we made it clear to the third lot that the question was, how can we do this, not why can't we do it? And guess what? How many legal changes do you think had to be made to make this happen across 3 jurisdictions with an integrated application? 0. It required a mindset change of how to interpret legislation and a willingness to go outside of the box. Okay. So the second thing that was a learning point there was we engaged the privacy commissioners in both the province and the federal government relatively early on. Now, I have to tell you, the bureaucrats were terrified about doing this. The privacy commissioners sat there and said, wow, this is really good. Why don't you guys come to us with more of these ideas? This is so obviously the right thing to do. Yeah? Now, we had taken a lot of time and effort to cover off some of the concerns that people might have on privacy, but the fact is that we found something that was so obvious to do from a citizen point of view that people believed in it and allowed us to do it. It's now been live for 3 years. Second example is out of Belgium. This is something called the Crossroads Bank for Social Security. Don't get confused. This is not a bank. This is not a data bank. That bit in the middle is not a central database. This is an organization that was set up to facilitate the exchange of information or access to information across the over 2,000 different actors in Belgium. Now, you have to understand Belgium, it's a small country, roughly 10 million people, but it has 3 levels of government and 2 parallel systems of government. Right? They have the Flemish and the Walloon governments that are completely parallel from top to bottom, and over 2,000 institutions involved in this. And what they did there is they changed the concept of what is information. And they basically said, we're not going to actually allow people to copy information. We're not going to allow people to duplicate it. We're not going to allow people to replicate it. We're not even going to allow people to verify it. That's my big question here. Why are we verifying information if it already exists? Right? They allow people to access the information. And what they work out is who has the legal right to collect the information, who has the legally defined source of the official source of truth. And then they work out who has the legal right to access the information. And if the two are then in agreement, then they allow you to access the information directly. Now, the only time you're allowed to keep a copy of the information, by the way, is if you've made an eligibility decision and you need to keep a copy of a record of what that decision was. You're not allowed to use it again. Only for the purpose of record keeping. You want to do another eligibility determination, you go back to the source and get the official source of information. Okay. Quite radical. So the Crossroads Bank is just that facilitation organisation that does that integration. They have some of the strongest privacy rules anywhere in the world, right, to manage this and to coordinate this. Now, just put it in perspective. We're talking about costs. These guys cut 7 billion euros out of the administrative budgets of the actors involved in that. Now, just to scale that up, it's not directly comparable, by the way, to the US system, but if you scaled it up on either a population or a GDP base, you're talking roughly $300 billion a year, because they eliminated most forms of interaction. Right? Almost everything that was involved in an inter-system communication or an inter-actor communication, a health insurance company to Medicaid, or whatever example you can think of, all of that was completely automated and eliminated. My final example is in New Zealand, different type of example. This is something called community links, and this is about changing that focus from outputs to outcomes. What these guys did, they said, we have communities that need a lot of help, and what we're actually going to do is the government are actually going to put the facilities in place for everybody to come together. Now, this started off as a non-technical project. This was a real estate and a business management type discussion, but they basically they do have a full multi-channel strategy, and this is part of that strategy. But what they put together was a focus for the people that are most in need in their community. And then they invited everybody into that environment. They didn't have the normal issues of, they did have the issues, but they dealt with them, of who works for who and all that stuff. They basically put everybody in the same building with a front-end referral system, so that when you walk in the door, you're not getting referred to another organisation that's half a city away. You're getting referred to an organisation that sits over there. So if you're about to be evicted, you go immediately to the housing guys, and they sort you out, and then you come back, and then we'll figure out what the next issue is. The third sector, the community organisations, they're all in there. Yeah? It depends on the issues in the community as to which community partners are actually in the Community Links organisation, and that varies around the country, but they're in the same place. So you don't leave that building until you've actually got an outcome plan. And that's the model that they're operating on. Now, they're in the process of retrofitting the technology in there to support that in a more integrated way, but they didn't have to wait for the technology. Now, all these three examples have a couple of common characteristics about them that some of them which we talked about yesterday. First of all of them were told it couldn't be done. All of them had strong leaders who sat above that and said, this is the right thing to do. Now, how am I going to get the political, the bureaucratic, the community support to actually make this obvious thing to do come to a reality? And all of them built sustainable governance frameworks. I think someone was talking about this earlier on, that when Bill Hazel was talking about this earlier on, when they left, and in one case the leader did fall foul of some political issues and got moved on. the thing was self-sustaining beyond the time of the visionary leader who set it up. All of them had that characteristic. The second is that they all looked outside their comfort zone. There were no templates for these people to do what we're talking about here. They all started from scratch and said, what would I do if I had a clean sheet of paper, knowing full well the reality was they didn't? But what would be the right thing to do? And then finally, all of them put the citizen at the center of their service design. And I think that's a key thing that we'll keep on coming back to. So just moving on a little bit back to the US. Of course, with Curium Software, we do deliver eligibility enrollment systems and in support of the Affordable Care Act. That's a clear thing we're doing. But we're really focusing on also that building the on-ramps to the health and human services programs. And what comes beyond that. And Walt's going to talk a bit more about what we see coming beyond that and give you a hint. Bill talked about it a bit earlier on. San Diego talked about it earlier on. We're very much in line with where their thinking is. We took active participation in the Health IT Committee and really providing guidance around the importance of the consumer-centered approach. We do believe that is a critical thing, as you've seen in those three examples and other examples people are talking about. And, of course, our involvement with the pre-Affordable Care Act states like Utah and North Carolina really fed into our concepts, what we're thinking about in terms of what may happen with healthcare reform as we go forward and the integration of health and human services as we do those. Finally, just to finish off my section, what about the future? Well, what we're really very excited about the next stage of where we see health and human services coming together. One of the things that combining with IBM has really allowed us to do is to bring together our experience in social programs with their experience in healthcare and actually look at the intersection between those two domains and what will the world really look like in the future. And Bill actually talked a lot about some of the things that we're also looking at as well. To have two of the largest IT companies in the world focused on the same area, I think actually says something quite profound. And no, we didn't collaborate before this discussion, so I think that's quite important. So that's where we see the next area of opportunities, and I'd like to hand over to Walt to talk through some of those ideas.
Thank you, Martin. Just to make sure everybody knows, Ronan didn't make it. Feels really bad. I thought I'd distinguish myself. I'm wearing a tie, something he would never do. And I promise I won't tell any off-color Irish jokes as I go here and talk about some of the work that we've been involved in, over the past few years, but maybe more importantly, kind of looking forward. And we're really excited about the opportunity we have with a bigger toolbox, a bigger scale with IBM, as this points out, is really to bring the human dimension to government, to combine social care, to combine health care, as well as human services deliveries related to public safety and education. So I'm going to talk about kind of where we think things are going and why, and talk about why this is an opportunity. I think Olivia talked about innovation is an opportunity that is born by, timing. I think the timing is good right now to really be thinking out of the box and move forward with integrating care across health and human services. And I think it's an opportunity to talk about what interoperable business processes are, a new service delivery model, how we should be thinking about delivering care, creating a continuum of care for citizens, and talk really briefly about some things that we're looking at from a research standpoint. Bill did a great job of talking about, how much money, what the spend is involved. A couple charts that just shows trillions of dollars being spent and 20% of GDP being spent on health and social care. A big reason that's there is that what we do is we build transactions-based systems. We don't build outcome-based systems. We focus on programs. We don't focus on people. We focus on reducing administrative cost, automating efficiency. That's what kind of the core things we've been doing with our technology in support of our business processes. You have to do those things, right? But that is kind of where the system is today, and it's not sustainable, as Bill highlighted. I mean, I took this thing from a blog in the Washington Post. They were talking about Don Berwick, some studies he had done. But, you know, within the next generation, the next 25 years, if the U.S. kept doing what it was doing, health insurance premiums would cost more than the median family income. So something's broken, right? And, you know, as Bill pointed out, it's about cost. You know, at the end of the day, it's about lowering primary spend. If you really want to affect change, if you really want to break out of the situation that we're in. And this is a great study that University of Chicago, Chapin Hall did. It's a big data analysis. They took data out of their eligibility system, their child welfare system, their corrections system, and resolved down families that were receiving multiple services. And it's the 80-20 rule. I think probably everybody in this room understands it. But it's the first study I saw that took a really hard look at where is this broken? Where is the system breaking down? Because it's clear that the system breaks down when complexity is introduced, when there's multiple needs, multiple services required. Our systems, our service delivery systems really aren't built to support them. I talked to the folks that did this study, and I said, well, what did Illinois do after that? And no disparaging comments to Illinois, but they said, we needed a service delivery strategy. We needed technology. We needed a capability in business processes to help us solve this problem. And I think what's happening in healthcare, this is from kind of the triple aim focus. Bill talked about, you know, quality, cost, and really consumer experience. But what we keep hearing, it started, I was listening for this because this was one of my questions, is who's talking about the social determinants of healthcare and the massive spend that's coming here? Dr. Gaskins brought it up yesterday. We heard Gerry talk about it. You know, Bill talked about how social care and health care were parallel systems, very similar in approach. And really what I think this says is, let's look at that, but more importantly, let's look at the service delivery approach that we have to solve this problem. Let's look at the citizen, and let's start looking at how you engage that citizen and start bringing the stakeholders together. Bill talked about coordinated care. That's kind of the secret opportunity, the flip side of the coin of healthcare reform and the Affordable Care Act. Taking medical homes and turning them into health homes, where the focus is on bringing not only coordinated medicine and medical care, but coordinated community supports and community and social programs together to affect change and to lower cost. Community care in North Carolina takes this approach. Studies show they saved $1.5 billion doing this by integrating social supports, the community, and the delivery of health care. Oregon just received a $2 billion waiver where care coordination and outreach workers are the core about lowering health care costs in the state. The governor said if every state followed that lead, we'd balance the budget and we wouldn't have the standoff that we're talking about. New York, Governor Cuomo, his Medicaid redesign team, they announced their intention to go for a $10 billion waiver with Medicaid. And health homes were a key part of that, as well as bringing in housing supports and intensive case management to support the high-risk, high-need clients that break the system, thinking about service deliveries that will support that. In San Diego, we've been talking a lot about San Diego, the Project 25, and Gerry mentioned that there's more than 25 people, but it's looking at the vulnerable homeless population that were high utilizers of emergency care, and they've seen a lot of success by integrating health and social. So for those of you that aren't social workers, this is a genogram. And what we think is critically important to managing those social determinants is to understand social context. And I picked this not because I'm a social worker. I'm an electrical engineer by training, okay? I've been taught by experts like Martin and Ronan and all the fabulous customers and subject matter experts that I work with. But Gerry talked about visualizations of data, and I can't remember if it was a side conversation or up here. But what's really important is that you start looking at context in the sense of relationships. Social workers use these to understand what relationships are working, what are broken. That's what the different lines mean. They look at what the social determinants are. What are the strengths, needs, and barriers? What's the social network and the supporting network to deliver care? And this is important because if you're going to design service delivery around the citizen, you need to engage them and their support, community supports, programs from government as well as their family, and start designing outcome-based plans that they're committed to, that they're engaged. Use their Xbox, use their mobility, use the people around them and the community to be healthy and start achieving outcomes. And that's what's really important, we think is really critical about when we think of tools and approaches. It's got to start with the social context as you're entering in to gaining support on both the health and social side. What's also important is not just looking at the high-cost, high-need population that are driving costs. That's a strategic aim. But you have to be able to support the spectrum of patients and clients coming through the door, right? Consumers, families that are coming through the door, and be able to support it across a wide spectrum of response. So the high-need, high-cost clients are the ones that you would go with rehab and prehab. Prehab if you can catch them early. Rehab when it's a chocolate mess, as Ronan would talk about. But you also have to deal with, the ACA vision of the policymakers of low-touch or no-touch processing or diversion into the communities, as well as your classic kind of transaction-based case management processes, as well as handling things like crises, hospitalizations, and violence in the home. And what we see is we see customers starting to do this. Child welfare's got differential response, alternate response. A lot of good work coming out of Minnesota that's influenced a lot of jurisdictions. But also ACF is now funding service delivery strategies based on a differentiated response. Health homes do that. Disability customers like WorkSafe BC in Canada do 80% of their claims processing and service delivery with no touch at all. And that's a workers' compensation program. They focus their human intervention around the things that drive those primary spend that they have within their agency. And we see it in the disabilities area. Queensland in Australia, they have a full range of differentiated response and specific engagement pathways with the citizen that are based on evidence-based protocols to support their program that's called Growing Stronger. And I think it's a really good model, and just the name tells you that it's citizen-centric and that it's really about providing proper care. So we think kind of the model really is we need to start talking about the enterprise as the citizen. Not an enterprise for health, not an enterprise for human services, but it's really to have the enterprise, the social enterprise, respond to those 6 basic needs of health, food, safety, shelter, education, and income, and then have a differentiated response around that. At the end of the day, it's like good parenting. You need to get a shared commitment from within the family around, making sure people are taken care of. And I think if a service delivery model with a mission, and a vision like, kind of Healthy San Diego, as Gerry said, it was important to inform what's happening, within the agency. I think it's about this. It's about understanding these needs and responding to them. So we've developed what we call a conceptual model that we call needs to outcomes. that takes clients, families, consumers, patients, what have you, from a needs base to an outcomes base. And what it does is it provides guidance and a conceptual business model in which to build applications that are centered around the citizen and are program independent. It still features that transactional capability, a case management that has eligibility and enrollment, managing providers, managing information and participants related to your program so you can pay benefits. But more importantly, it's about engagement. Martin talked about engagement. But having that universal on-ramp, like that's envisioned with the ACA, which we're talking a lot about with exchanges, that gets you on programs. But also understanding what kind of engagement response that you need, what kind of pathway, what kind of differentiated response do you have based on your social context. And then most importantly, to really address the high cost, high need is the capability of moving from outputs to outcomes, but a whole outcome management capability that does the assessment, the planning, the evaluation, the coordination of care and teams so that you're able to go from understanding who's coming in the door, and there were some discussions yesterday about you don't need to understand what programs are available to you, but how do you get connected to government programs that's a contract to pay benefits or community organizations, and how do I kind of get through the system, whether it's classic case management or a really high cost, high need to kind of manage the outcomes. And these things can be deployed separately, right? You can put a no wrong door on the front of your systems, on the front of your programs. And you can also integrate service delivery on the back end of this, or you can kind of modernize your case management. So this is our conceptual model, and I think it fits really well with where the world is going as far as integrating care and on both the social and health side, and really even the public safety and education side. So, this goes on, and as everybody knows, I'm going on and on. And I can go on and on, believe me. It's people that know me. But there's a whole kind of build-out, data models, process models, service delivery models, and it all kind of comes together in a platform that's configurable, that's extensible, that's program independent, that's designed around that conceptual model of needs to outcomes. And this is an area, as Martin said, of focus for IBM. It's about bringing that human dimension to cities, to states, to national governments, that you can integrate care, you can do wraparound care, you can differentiate the type of care that can be delivered, and we think that's really important. And because there's a big toy box now, because there's scale, because there's lots of technologies, it affords us the opportunity to really look hard at how we take the platform and support this conceptual model and enhance it and complement it. So on the left-hand side are a set of kind of design points. How do you kind of create that outcomes to outputs or engagement model? Gamification is a great example on engagement, but also it's just as important to collaborate and have a multidisciplinary team approach. On the right-hand side are areas that are really kind of real opportunities to look at social context and the analytics that can bring alive things like a genogram. I'm not saying that that's the tool for workers, but to be able to create that visualization so you understand context. How do you achieve good social and economic ROI? Because if it's a cost problem, if it's a primary spend problem, you need to be attacking both the social outcomes, right, as well as the economic outcomes, and do it in a smart way. So building out models around that. The various engagement pathways that are practice-specific and domain-specific, And then we're talking about engagement centers. This is user experience for all of the stakeholders across different channels and devices. And Bill did a great job of talking about where that's all going. It's kind of mind-boggling. But really thinking about optimizing, and somebody said it yesterday, maybe it was Dr. Gaskins, about don't just think about the citizen. And this was part of the HIT committee discussions. You got to think about all the stakeholders and all the business processes. You need to support your providers, your MDT community members. You need to support, obviously, the family and the citizen. And then lastly, it's exchanges, because I think that's where a lot of interest is. Martin talked about what happened in Belgium, but it's exchanges around being able to get the right information at the right time in a very federated way, in a dynamic way that's secure and contextual, right? That's a lot of words. But it's about interoperability. How do you take great technology that can do that in models that are out there? I think Izzy from New York City might be talking about some of the work they did there. But it's also about exchanges of data to create these big data warehouses that the folks were talking about as well. So you can build policy, so you can know what works. So hopefully I didn't go too far over. But this is kind of how we see things going, the real opportunity here, and maybe the next 10 years. And let's use the perfect storm and the perfect opportunity of funding to kind of move the world forward. Thank you.
So thank you, Martin and Walt and Bill. So what we're going to do now is this particular session was designed to give you a kind of an insight into how industry views the world that they're providing service in. And so I thought that there was a lot of content that was a part of that. And what we're going to do is we're going to use a fishbowl technique, and we have 4 individuals that we'll introduce, and we're going to use that as a way in which to have a conversation. I'm going to ask the 3 of you to move your chairs out from behind and bring them over here, and I'm going to ask the fishes to move into the fishbowl. And I don't know how many of you have seen this technique before, but the idea is to provide them with an opportunity. Why don't you guys come over here?
We get the comfy chairs.
Yeah, we're going to turn you around to the audience. So the idea is that they've been agreed to take copious notes, I noticed, and they're going to be a first responder to the whole process of the presentation. And then there's going to be an empty chair here that's available for any of you in the audience who might want to participate. All right, and so we're not going to ask for questions from the audience, but if you feel so compelled, come and sit in the chair and join the conversation. Now, a classic fishbowl technique, if we had another hour, which we're not going to do it because it's lunchtime, we know, would be that you would be able to kick people out of the fishbowl, right? And so participate in that. And so what we did is we asked 4 of our sponsors who are represent industry, to also participate in this. And so I'm going to introduce Bill and Davenhall, Bill, from Esri. And we've got David Hansel from KPMG. We got no name tag, right? But we have Kathy Fallon from TCG, and we have Peter Quigley from NCCD. Okay? And so I'm going to sit and join the fishbowl. It's kind of like more of a fish dish because, rather than a fish bowl.
You know what happens to fish on dish.
That's right. That's right. All right, so again.
Dish.
So I think it was a great, so I'm going through the opening statement, and then I'll ask you to just interact with each other. So it was very, very interesting content, and the economic impact that you both spoke of, and the large systems approach. And citizen engagement were a very significant part of all 3 of the presentations. So I'm just going to give you the softball question. From your unique perspectives in industry, what were you seeing or heard that was unique, or something that you in your own work would like to comment on?
I would say today was really refreshing for me, because there have been so many conferences the last 18 months talking about interoperability, and I would suggest that it's been feeling like a treadmill where everyone's running at high speeds. but we haven't talked so much about what we're trying to get to. So I think San Diego really summed that up today, where their efforts are focused around very clear objectives, not about getting people insurance, but what you're trying to do to their health. And I think that that was really, really refreshing to me. And you all, the three of you, talked about the same thing, like what are the outcomes? So my only question to the group is, if we start to focus on those things, how do we work in government systems that have built enormous bureaucracies about micromanaging inputs and throughputs, and so much less emphasis on actual outcomes?
Well, I'm not sure I'm going to answer your question, but I wanted to comment. All very interesting presentations, and I thought I'd start at the end with Walt. I thought your point about differential response really reinforced the point that Uma made yesterday about focusing on both the front end and the back end, and I think that's worth maybe discussing a little bit. And by back end, I don't mean infrastructure. I mean care coordination, case management. We're obviously focusing in this conference and today, and for good reason, on the front end, which is enrollment, eligibility, access, things like that. We need to, the mandates are there to do that, the funding is there to do that, it needs to happen. But getting people through the front door only gets them into the house. And then the real question is what happens once they're inside the house. And that in terms of achieving good health outcomes, and in terms of bending the cost curve, it's really all about care, the care that people get and making sure people are getting the level of care that really is consistent with their needs. So it seems to me the challenge, and I think Uma kind of posed this yesterday, the challenge for us all is, as we stay focused on the perfect storm of today and taking advantage of the opportunity, as Olivia said it, how do we also make sure we don't lose sight of the longer term goal, which is not just getting people into the systems and into the programs, but making sure that they're appropriately using the services to achieve good outcomes at an appropriate public expense.
Well, as citizens of Massachusetts, as Fishbowl 1, I would argue that there's actually been no movement to date on cost containment at all. In fact, it's higher, which would be expected. But also, I haven't actually seen, unlike San Diego, I'm not so sure I've seen much to suggest that we're healthier. Which is just interesting, because I think there was so much focus on, like you said, getting people an insurance card. Actually, maybe the focus, unlike San Diego, should have been a little bit more in tandem around what the hell are we trying to do? Do you know what I mean? It's not just an insurance card in and of itself. That's largely meaningless, right?
A couple things struck me. Is Dr. Bill still here? Yes, he is still here. I feel like a surgeon who's going to try to operate on himself. This is dangerous and probably not recommended. Right? Yeah. A lot of it, which also produces you ineffective, right? So, a couple things strike me. So I started my career about 37 years ago in a project integrating health and human services. So that was 1975. So I'd want you to just think mentally, where were you in 1975? Okay, so now you've answered that question. Okay, so this is not a new problem. This is a systemic problem that's a chronic condition. Technology by itself isn't going to fix this problem. It's going to, it's an enabler. It could enable it for the worse as well as for the better, but it's certainly a significant handmaiden to what has to happen. And I'm not sure I really understand after 2 days now what really has to happen. We have a mixture here of strategy and tactics interweaving back and forth. We have the sense of urgency that something has to be done now and it has to go this way or that way. And then we're also forced in this thing, well, what do we really want it to do? It's like we talked yesterday about arriving at the destination before you start to build the car. Try to think about how far you're going to have to travel. So the things that sort of reflect on this is, have you guys started to see any kind of ROI measurements in communities where it's not about the technology part of it, it's the whole crucible of ingredients that went into the recipe? Are you seeing communities who are now starting to market their processes and in their service integration as part of their economic development portfolio, so to speak? Are you seeing, I don't know whether San Diego's doing this, but I like it. Where's Gerry? Yeah, Kerry, I loved your words about wholesale and retail. You need to add some new words, receipts and warranties. And I would say this is where my experience 37 years ago broke down. We found that the system wasn't willing to give receipts nor warranties. And so while it looked like in many ways it was consumer focused, when we got to those parts, we unplugged ourselves and said, we're really doing this for the goodness of these people here, and they should respect that fact, and we have our procedures and policies, right? So it wasn't really a good economic model. So I'm curious as to whether you're starting to see the glimmers of this working in such a way that people use it as an economic driver.
I have a couple thoughts on a couple of those points. I think, so where I was going near the end of my talk, we are all over that question. That's why we are very interested in San Diego right now, because, and multiple other places, but because, when we were there, you had the chamber there, you had the mayor there, you had the programs there, and they went to metrics right away. They went, meaning the program, the community providers, the hook to the military, they were all working on what metrics are we going to get to, how are we going to measure them, how are we going to report them, and how's that going to create a continuous cycle. I think similarly, the other example I'd use, then I want to comment on your point, but I think the stuff that Single Stop USA is doing, for instance, with the colleges in the country is pretty interesting and really, again, focusing on an incredibly focused, we are going to reduce the dropout rate of the colleges, increase the graduation rate, and use benefit coordination as a strategy. And now, all of a sudden, having like 17 parts of the country looking at the results and pulling them in. So, and also going to your point, when you one of the other reasons I think at the local level, when I talked about convening the government officials with the big employers, the business is going to start where you were just coming from. Right there. What is your metric? How the hell are you measuring this? How do we know this is going to work, right? So I think that's relevant. One other point I'd make, and I think a couple people said this today, I think getting to the outcomes question as opposed to the interoperability question is where to really drive this discussion, because you'll get to the interoperability question. And also, as we look more about service modernization and new models of service delivery, both on the business and the government side, it changes us from thinking about interoperability between two systems that need to change. I mean, we're talking about connecting two broken systems often and developing an interoperability strategy for that where you need new models, right? Toward that end, I think, and this is kind of me in my prior life, some of the opinion I'm about to give, but I really think that if you were to look politically, this idea, there's been consensus here for almost 5 years on connecting health and human services. The dilemma, there's multiple barriers in the middle of that process. Some of it, and I was very impressed with the federal speakers yesterday, some of it is the regulatory stuff, the finance stuff, the procurement stuff on the federal side that the people in the room are saying, how are you going to help us connect the dots on that? I think that right now there is more of an awareness of the demand or the benefit, as I was saying earlier, to both business, government, mayors, others, industry, to start saying we really got to get to outcome measurement, we've got to do this. That I think you could actually, regardless of the political context in terms of the nation, in terms of the presidency, I think you could generate, instead of generating it here alone or with Washington Federal, I think you generate it right from the cities, the businesses, and others right into Congress and say this is just not tenable for us to continue to have this discussion. And I'll end by giving an example of that. I was, in my role as Tech America, I was involved in a discussion the last couple of weeks where one of the large payers, government payers in the country, is actually saying to the group, you know what, regardless of what we're doing with the states, for instance, as our large agency, we actually now got to measure more than claims. We've got to measure performance for providers in the country, and we don't have the ability to do it because we have 7 or 10 or 12 disconnected analytics systems in our giant agency. And maybe the only way we're going to get to that is to change the whole procurement process and move from a 10-year procurement process to a rating system where we take the 5 key outcomes that we want We create we identify platforms that could serve those outcomes. We rate them the way you would on a Google or a Bing. You can pull it up, that's a 4-star system and a 3-star system. And we eliminate the 10-year process, and we go into a 3-year process. And we say to the industry, come forth with it.
Okay, so Pete,
you know?
I'm going to take the microphone away from you, too.
Bill, I promised to hold the microphone still during this. I want to follow up on the other Bill's comments about outcomes. I agree with them wholeheartedly. But I think there's a problem that we have to think about as we move to mega data. And what's required, I think, in the future to get these metrics that we all want, to get the outcome measures and all of that, is we've got plenty of storage space, there's plenty of tools, but what I see is a deficit of skill sets. In other words, agencies themselves generally don't have the people with the skills, the long-term knowledge, domain knowledge, deep domain knowledge. And so to get to this place in the future, I think we have to start envisioning centers of expertise so that the data collected in San Diego or Virginia or New Jersey or other places moves to an area that might be specialized in Medicaid for analytic purposes. And that information is turned around. So rather than trying to have 50, 100, 200, centers, analytic centers, we have specialized centers that really can offer efficiencies and deeper insight into the information and how it's to be analyzed. So I'm the optimist. I mean, I think we're getting there. I think that's why they probably invite me back every year, because I believe this is really going to happen someday. But once you get there, you still have to deal with the problems of how are we going to handle the process and make this information meaningful and actionable to the social worker, the intake worker, and all the other people engaged in the system.
Just to add on to that, one of the things we've seen in Australia, in the UK going on at this moment in time, in New Zealand, is the government in those countries changed the procurement models for their interaction with the third sector, the community providers, on realizing, having contracted out whole swathes of activity over the last 20 years, they didn't actually have the information. And the reporting requirements that they were putting back onto the charities in Australia, there was one particular one where 60% of their income was spent back on reporting back to government, right, or governments. And what we've seen happen in the last 5 years in those countries is government, in their procurement models, have changed the way they use the IT systems, so that the providers actually put the information into the government system rather than actually having it in their own systems. And that gives the government actually the ability then to procure a wider range of providers and actually to do the data analytics. And some of those countries, like New Zealand, are now doing some very, very sophisticated lifetime impact and analytics associated with what is the cost of government going to be to you over the next 20 years? And what interventions am I actually going to make now to try to preempt, prehab as we call it, those activities? And there's some models like that going on.
One of the things that all three of you mentioned was this big dependency, which has to do with leadership. And I think as a strategic kind of question, obviously in these places that you gave examples, they had leadership who brought technologists in, brought system thinkers in, right, I would assume. That's not to say that you didn't go out and evangelize a bit and they got interested, but it struck me here that unless the leadership wants this to happen, it's not going to happen in a lot of the big places where we need it to happen.
I would just say, when people, these guys, you shouldn't forget, like, as a ancient old anthropology Peace Corps sort of background, the culture thing is huge. You can have the best technology in the world, you can have the best solutions, you can have a good leader even, but if they don't understand the line worker, resistance to change, it'll all go up in a ball of flames. I think about the Michigan SACWIS experience, and I'm sure the technology was quite sound, but it was a disaster because they had complete user rejection. I would say that the social workers, in my experience, have a resistance to analytics. because they imagine it replacing them on some level, as opposed to imagining it as a tool that can suggest to them perhaps an ideal course of action. It won't always be right, but it gives them a guidance. And there's a huge amount of resistance in the field to using analytics to help you make child welfare, public welfare, workforce decisions because people feel threatened. And so figuring out how to change that as a leader is going to be really important too.
I'll offer the audience the opportunity to get wet, come into the fishbowl if you have a question.
So I guess I have to speak since I'm up here. No, but I think there were 4 questions, if I'm tracking, right? One was, how do we get to this outcome-based approach with the workforce? I think number 2 was, differential response and what it might mean. The other one that I took away, Bill, was receipts and warranties. And Pete, yours was, at least I took away, is how do we actually deploy evidence-based models into the workforce so that they're effective, right? Analytics are going to drive that and actually make it useful. I think, and I think there was a question around advocacy and what their role could be. And I think what potentially the way to start thinking about this is to start building on this idea of a marketplace. Who are your consumers? Who are you focused on? And starting to build systems of care around social issues and community issues and balance those 6 core needs. And the thing that's going to get everybody, I think, on the same page is the amount of spend that we have. We just cannot sustain it. I think that, whether there's leaders there or not, a good leader like Bill Hazel, is focused on achieving something, but also, driving down costs. I think that creates, the opportunity for, moving forward. So I think social innovation, going after quick wins, making it very clear around, your systems of delivery and segmenting the type of service deliveries that you have out there, and being able to have systems that build on evidence-based models.
I was listening to Governor Engler, who said that the absolute best care management, cost control stuff is happening in the largest corporations that are self-insured in America. Better than insurance companies that when costs spike, they pass it on. Better than government, who just passes it on largely through appropriations. That's really where the magic is happening about changing health outcomes.
That forum we're doing on Thursday, we have a guy named John Kell from the West Coast, who's one of the lead guys in the Fortune 500 companies.
That's interesting.
Right onto that point.
Yeah.
Welcome to the
We
vocal
can learn a lot from it,
So, you have questions?
Peter Eckert from Illinois. And I guess it's kind of both a comment and a question, but one of the things that I've been thinking in the last day and a half is our propensity to espouse kind of client-centered focus and a client, and I would add kind of the line worker interaction as something that we highly value. And I really saw a lot of interesting stuff, especially in this presentation. I really appreciate that. But I wonder if one of the pitfalls that we fall into is that we continue to act on behalf of these folks who we put at the center, but we don't give them a meaningful way to participate in the conception, the design, the implementation, the testing, the evaluation, and your comment just now about social worker resistance. My guess as an ex-social worker myself is that often is a result of people not having a meaningful stake in the action. And if I had a chance to ask, all of you is sort of, what are concrete examples of ways that our consumers, our service recipients, and especially the line workers, both in community providers and in state government, what are the ways that we are providing, meaningful ways and accountable ways too, meaningful ways to participate in the process? Because, frankly, if we're not doing that, then we're really not, being true to this vision of a client-centered experience.
I think On the business side, which is a little bit out, but going to the point raised earlier, we're seeing some pretty interesting models that in terms of how businesses are engaging their employees and making it incredibly inclusive, particularly on the wellness question, so that they get it. But it goes to the point raised here, and that I guess I was emphasizing. This cost thing is the 10,000-pound gorilla in a whole different way than it was 5 years ago. It is the issue. It is the issue. It's the issue of productivity for the country, businesses leaving the country, government sustaining. So in terms of models, and then I'll come back to that in 1 second, but in terms of models, well, I know we keep coming back to San Diego, but I'd look at San Diego. I'd look at what Bill was doing when he first came into Virginia with his team. Just pulling them in and saying, how are we doing this? What are we doing? What's, being inclusive. And also, on the vision thing, I think you've got to have leaders who can at least say this is where the puck's going to be and where we want it to be. Not to get stuck on we want to interoperate across what we have. You will get to that if you have a vision that says where you want to be.
That is an inspiration.
But I think you absolutely have to go there. And if you go there the way you guys were talking as well with the metrics that you want to get to, then when you talk to the consumer or the worker, you're giving them something rational that they could buy to, which is by doing this, we're going to get to this. So much of the discussion is caught on systems don't operate from a technology point of view. How do we change financing to fix that? As opposed to who cares unless you get to certain metrics and outcomes that you want to achieve. You, I believe, and we've seen people get the buy-in when you take it down to the level of how do we achieve X, A, B, C outcomes.
You were talking about concrete examples. I guess I could share a few that come to mind. The idea of having an enrollment portal of customers, they're extending that to actually have an account with your government agency. And to go beyond that with health insurance exchanges is now to have some self-direction on benefits that you're choosing. The UK is doing some interesting work in self-directed care, right, Martin? In the disabilities area. So I think kind of an online presence, that you're actually involved in. Well, I think there are a lot of states are, but going beyond just enrollment, but an actual relationship and an ability to choose and select benefits, to be connected not only to the government, but two-on-one type systems with the communities. I guess that's one example, right? New York City, 35 programs across 12 agencies, but that would be one example. I think another is actually having domain-specific collaborative workspaces, right, where you're actually engaging the family, right, in planning around their outcome plans or their service delivery plans, and being able to enable providers and supports to kind of support that on an ongoing basis. So actual portals, it could be a provider portal, that's out there. That's encouraging buy-in and capability to be able to support service delivery across multiple stakeholders.
I think one of the things that was really valuable about all your presentations, and you're demonstrating it, is bringing non-U.S. examples to the table. I think all of us, in my former, all of us who are or used to be government managers, I tend to lapse into that a bit. In our day-to-day managerial work, we're very much bound by the context in which we operate, the statutes, the regulations, the funding streams, and we have to be because we have to work within those. But to hear about what's happening in other parts of the world really takes us outside that box, and some of it can be transferred back into the box. But I think it's tremendously valuable to have and that's one of the things that I think industry partners, private partners can bring to the table is experiences from way beyond the context and the perspective within which we operate every day.
I mean, these guys do that all the time as well. But for instance, when we're looking at a county, we're thinking of the fact that the people say, is this a representative county? By size, like you go to San Diego, that's a perfect size place. It's not as big as the whole state. That's hard to create change, right? But it also has context in terms of you go to Germany, which is kind of a system. So when we look at this stuff, we're always thinking of context of what's happening here, how does that apply to other parts of the world?
Well, we're coming up on the lunch hour. I'll give you one.
I was just going to comment. We do a lot of work internationally, and of course the observation our team makes all the time is that the United States is very unique. You leave this country and you have hospitals and human services that are combined in the same ministries, and there's suddenly a lot less walls to climb over to talk about service integration. You come into the United States, we've got every state is different. You have health here, you have public health here, you have human services over here. So I mean, you need to think about, is that an important strategy, a leadership strategy to consolidate this and put all these agencies, families and children's and social services and health services together? And I know that's it's probably heresy, but I'm saying at the same time, the observation internationally is you go into some of these countries and you can go to one ministry and speak to all the people who serve the citizen in the health and human service space. And here we have so fragmented it.
Europe doesn't put necessarily the client in the middle, it's more societal. That's the interesting part of the different mindset.
Necessarily as simple as they have their own investment.
Right.
But I would say from the get-go, it looks very different, and it smells different, and it acts different, and yet they do the same things we do, generally speaking. So, for example, the best practice of never having to touch one identification over and over and over again, how come that's not a best practice in the field of service integration?
So I want to thank you. I hope it was a great dialogue. I think the theming around this whole issue of the citizen and the focus on the consumer and how we're talking about larger economic trending and larger ways in which we're addressing all health care, like San Diego, and healthy communities in general. I think it was really a great opportunity to have a conversation and a reflection on how you and your roles in support as an industry, approach communities and at different levels at all kinds of jurisdictions. Thank you again. Can we get a good hand of applause?